Welcome to Reframed, a podcast created to educate, encourage, and inspire parents and professionals. The Gladney Center for Adoption staff know parenting a child that has a history of loss, abuse, neglect, or trauma requires parenting skills and insight to be reframed in order to create a loving and caring environment. Reframed host Emily Morehead and guests strive to make an impact on our world through topics that are important to you, your family, and our communities. And now, here's your host, Emily Morehead.
Hi, and thanks for joining us for another episode of Reframed. I have Kobi Tobin, who is a NICU nurse, joining us today, and we're going to be talking about neonatal abstinence syndrome. Kobi, thanks for joining us.
Thank you so much for having me.
Tell me about your experience.
So I've been a nurse for 7 years now, and ever since I was just a little nursing student in the NICU, I fell in love with babies with neonatal abstinence syndrome, and always knew I would do something with their care as I progressed through my nursing career. So first project I did as a student, working with how to take care of these babies. And then as I progressed and took care of more of these babies, I always wondered how do we interact better with our families and support bonding with babies with neonatal abstinence syndrome. So for my graduate work, I provided education on NICU nurses on not only neonatal abstinence syndrome, but also addiction and how to best interact with women with substance abuse disorder. So then we provided that education for them, and the wonderful thing is now we have so much more information on neonatal abstinence syndrome and what it looks like for these babies, and then long-term what it looks like for them, and that body of research is just constantly growing. So I hope that our care of these babies will just continue to improve, because it's already improved over the last 7 years.
Yeah, and you told me the stat when you started in the work, it basically has quadrupled, and so right now, correct me if I'm wrong, but the statistic is that every 15 minutes there's a baby born withdrawing or experiencing some type of neonatal abstinence syndrome.
Yes, unfortunately that's correct, and that's just increased. When I first started looking at it, it was about a baby every hour. So just over the last less than 10 years, it's increased dramatically. To our viewers who don't know what neonatal abstinence syndrome is, it's when a woman uses primarily opioids but other legal and illegal substances during pregnancy. They can cross the placenta and expose the developing baby. And then after the baby's born and that umbilical cord is cut, the baby can show signs of withdrawal that require special care and sometimes medication management until in the hospital until they're able to go home. These babies, sometimes some of the symptoms of neonatal abstinence syndrome are high-pitched cry, tremoring, irritability, sneezing, fever, fast breathing, signs like that. So it impacts both the neurologic and typically the gastrointestinal systems as well. Every baby's going to look a little different, which can be challenging. It depends on what substance the baby was exposed to. If a baby was exposed to multiple substances, they oftentimes will have more severe signs of withdrawal. But it also depends on how much of the substance was used by the pregnant woman, the frequency of use, purity of the substance used, and then your comorbid factors. So what's mom's health status? What is her mental health status? What does her nutrition and prenatal care look like? And all of those other environmental and health factors that impact the developing baby.
I know a lot of times we hear from women, they knew that they used a substance or they were battling addiction, and there was a big fear of receiving prenatal care or sharing with healthcare providers about their information. Sometimes we even have women fear, sharing that with our social workers at Gladney. Can you talk to me about the addiction cycle with that and the fears with that, and maybe some of the barriers to receiving healthcare for these women?
Yes, so as a society, there's definitely a stigma associated around substance abuse during pregnancy. And so there are women who are pregnant who are battling addiction or use different substances, and they may have guilt about using it, which limits their ability to speak with healthcare providers. But there's also fear of legal consequences. And then if they have other children, fear of CPS either potentially removing the other children or the baby after the baby's born. But we definitely encourage moms to always be open with their healthcare providers so that they can provide the best care for them and hopefully in a non-judgmental manner. Yeah. Some of the other barriers we see is lack of childcare for other children at home, transportation to and from doctor's appointments, availability of doctor's appointments with either lack of insurance or no insurance at all.
I think when we're talking about like addiction history, obviously ideal world pregnancy, you're able to receive health care, you're able to talk with a practitioner openly, you're able to take those prenatal vitamins and take care of your body well. And with addiction, those two don't always match together. So when we're looking at moms who are struggling with substance abuse, can you talk to me about like how your team in the NICU even reframes how they're serving these parents?
So we first encourage them to be open with their healthcare providers so that if they do need treatment while they're pregnant, they're able to receive that treatment. And then after they're born, ideally prior to delivery, the woman would be set up with education on if we anticipate the baby will have neonatal abstinence syndrome, what that will look like, what care in the NICU looks like. Mm-hmm. And then once if the baby does end up in the NICU to receive care, it's close monitoring of the baby, but it's really a lot of focus is on interacting with mom or the primary caregiver, and really promoting that bonding with the baby to provide better care and so that they're able to have the best outcomes and hopefully go home relatively quickly.
Yeah, absolutely. And I know that with families that we're working with at Gladney who may be adopting a child who had some type of drug exposure, obviously there's questions of like how much, how often was that drug utilized? And we're seeing a spectrum with the women that we're serving in our community of drug usage and trauma history and with that addiction. Can you tell me when families are trying to make a decision about the child that they're able to care for, what information would you like for them to have about NAS and maybe the research out there about it?
So there's increasing research available on different substances abused and what that looks like in the neonatal period, and then some information, long-term follow-up of the neurodevelopmental outcomes, which is typically what most parents are concerned about. Yeah. The research I found really says, one, we have trouble differentiating because there is a fair amount of polysubstance abuse, so a woman who uses more than one drug or medication during pregnancy. So that can influence what neonatal abstinence syndrome and the symptoms look like in a particular baby, and then long-term what that looks like. Okay. And then the other common in the research is, we see different neurodevelopmental outcomes in children that were prenatally exposed to different drugs. However, what influence does the environment have on those children? And the environment may be different in an adoptive family versus a child that's going home with mom who has substance abuse disorder. So I think, one, it's good for any parent, particularly adoptive parents, to know what substance the baby was exposed to in utero. Acknowledging and ensuring that the pediatrician's aware of that. And then just like you would any child, you're going to follow their development, work on their development, make sure they're meeting those milestones. And then particularly once they start school age, if they start having difficulties in school or difficulties learning, just like you would any child, get them the resources and the interventions early so that they're able to overcome any barriers or have any modifications they need so that they are able to be successful. But we do know that environment plays a large role in child development as far as what they look like as they get older.
Yeah, I think that's what's hard for me is when I've gone through the articles, and like you've said, there's so many more out there, so much more research being put out, which is amazing, and we're hopeful that continues. I think what's hard is that the environment changes in an adoptive home compared to a home that is going to battle with substance use. And so understanding the research and how it applies to that child is really difficult because it's just not quite out there with adoptive families. And so it's kind of helping them understand nurture versus nature and figuring out, well, what resources do we have that we can, plug our child into if necessary, and also acknowledging that that environment might mitigate some of those effects as well.
Yeah, and the research is clear that each child's going to be very different in how they respond. There's a lot of genetic factors that influence child development and influence their response to what they were exposed to. So the best thing they can do is just really follow the development and then intervene early. But honestly, you would do that with any child, and sometimes we know diagnoses and disease processes prenatally, just like you would if you were adopting a baby with substance abuse. And then sometimes you don't find out your child has a diagnosis or has a disease process until later on, and then you intervene at that time. So I completely understand how it's scary, because there is research that supports that some of the children do have long-term neurodevelopmental and delays and behavioral issues, but that's not every child. So you just have to do the best you can and go from there.
Yeah, meet that child exactly where they're at, just like you would any child, just following their lead and figuring out what their needs are.
Exactly.
So tell me about soothing. Initially, when you were describing some of the withdrawal process, like that sounds really difficult for those babies. So what does the NICU do with medicine to soothe these babies? And then what do you guys do just for soothing comfort measures?
So we typically start with non-pharmacological or non-medication therapies. There's a fair amount of research out that supports what we do. The babies, so the nurses will score the babies based on their symptoms of withdrawal, although that's primarily to determine the need for medication management and adjusting medications. But we score any baby that we think has a potential for withdrawal, signs of withdrawal. But some of the non-pharmacological measures we use are rooming in. So if the primary caregiver is able to stay with the baby 24 hours, that's really, really shown to be beneficial to the baby. As attentive as your NICU nurses are and your NICU staff are, you can't possibly be with one baby for the whole 24 hours. Sure. So if you can have a primary caregiver there, able to console the baby and comfort the baby, that's ideal. It also promotes bonding with the baby. Skin-to-skin contact, or we call it kangaroo care, so holding the baby skin to skin has been shown to have a calming effect and decrease signs of withdrawal and hopefully medication, the amount of medication they need and duration. Some of the other things we do, rocking. These babies tend to like to be rocked vertically versus horizontally, okay. So up and down. The pacifier for that non-nutritive sucking. We talked kind of about the symptoms earlier, how these babies oftentimes are excessively irritable, have difficulty sleeping, and so they may need higher calorie requirements than a otherwise healthy baby. So small frequent feedings can be helpful for them. Also, we'll see vomiting and can see diarrhea as part of the withdrawal process, and so small frequent feeds sometimes helps with those symptoms as well. Let's see. Lastly, swaddling has been shown to comfort these babies. Stimulate really easily. So if there's a loud sound or if there's noise from other babies, they can be stimulated, and then it kind of precipitates a cycle of irritability and difficulty sleeping and trying to feed, but maybe not having the control to feed a full feed at one time. So swaddling can kind of help prevent the self-stimuli, so where they startle awake, and can be comforting to them as well. Okay. As far as if the non-pharmacological or those non-medication therapies aren't working, then, or if the baby has really high scores, we introduce medication therapy. So the primary supported medications used are methadone or morphine, so both narcotics. And the research supports having a standardized protocol for weaning. So you'll start at a therapeutic dose and titrate based on the baby's symptoms. Okay. And then ideally we're weaning those babies off in a standardized manner while monitoring their signs of withdrawal. Okay. Sometimes we'll see it's kind of that last little dose that can be very difficult to get the baby completely off of, and then we of course want to monitor them for several days after to make sure we don't have rebound signs of withdrawal and they are safe to go home as long as medically they're healthy otherwise.
I think sometimes that can feel scary, right? You're saying methadone, administering that to an infant, but the addiction cycle between someone who's using and making the choice to use, or their body is driving them to use, versus an infant who's being dosed that by a medical provider, they're not able to go out and, seek that as like a long-term addiction pattern. So I think it's helpful to differentiate that.
Yeah, so addiction is a chronic primary disease with the reward centers of the brain, and like you said, they're making the conscious decision to take a substance or have an inability to stop taking a substance. Whereas with a baby, there's no such thing as an addicted baby because they don't have that development yet. It's a physical dependence. So they've been exposed to this, primarily narcotics is what we're speaking of. And then once that umbilical cord is cut, they're going to show signs of withdrawal because they've been exposed to this potentially for the first 9 months of development. So with the physical dependence, it's not addiction in once, but if you were to stop giving the medication, so like once that umbilical cord is cut, they can show signs of withdrawal. So by giving the medication, you want to ease the signs of withdrawal so they're able to do normal baby activities. So they need to be able to eat so that they're growing. Failure to thrive can be common in this population because they're not getting the calories they need. They have increased movement. If they're crying a lot, have that irritability, they're burning extra calories. And then the tremoring can also increase the calories they're burning. So then you're weaning them off of the medication to where they no longer need it, no longer have that physical dependence for the opioid. So yes, addiction and physical dependence are very different. And you'll hear people miscorrectly say that the baby was born addicted, and it's not true. They were born with a physical dependence to whatever substance mom was using.
Oh, I haven't heard it reframed like that. I really like that because that's helpful to understand. Because it feels scary as a parent to consider that your child may need that. And so that reframe is helpful for my mind even to just process that. And
methadone is, I completely understand where coming from. Methadone can be a scary drug, especially if you're not familiar with it. There are benefits. The research is starting to show that if you use methadone over morphine, which is just a shorter acting narcotic, the babies in some studies have shown to be able to get off the medication sooner and then thus discharge sooner home with the family, which was best for everyone. So
Absolutely.
Definitely encourage parents, or adoptive parents, if they're in that situation, just to talk to the providers, ask for education. Hospitals are really good about providing education on anything that's going on with your child. So definitely ask for that and kind of what the plan is and those sorts of questions can hopefully ease the parents' mind when it comes to dealing with these medications and these situations.
Absolutely. You were talking about rooming in. Is that something that's helpful also for adoptive parents?
Yes. So, and I've seen this in practice when anytime you have a baby with neonatal absence, and whoever the primary caregiver is, if they're able to be there with the baby as much as possible. We always encourage our families to be involved in the baby's care. But it really, the research shows that you have the rooming in, it not only supports the bonding, but can decrease some signs of withdrawal. So it would be great. I would definitely encourage adoptive parents to be there. I've seen, in my experience as a NICU nurse, differences in babies that have that primary caregiver there, who are calm and able to intervene and meet the baby's needs. Oftentimes on paper you would say, oh, this baby would require more medication or should have higher withdrawal scores, and they don't. And I wonder if it's attributed to that rooming in and that ability of that primary caregiver to be there and help comfort and care for the baby in addition to the medical staff.
Absolutely. That would make sense to me. They're meeting that emotional need of comfort and soothing. And so that's a really neat measure that I love hearing that NICUs are actively implementing as a treatment protocol.
Yeah, and if there is not a primary caregiver, which does occur sometimes in these situations, a fair number of NICUs utilize volunteers or cuddlers, as they're called, to help comfort the babies, and extra staff utilized for those measures so that the needs of the babies are met, even if sometimes the primary caregiver is unavailable.
I've had the opportunity to do that a few times, and those are some of my favorite afternoons at work, to just get to go snuggle a baby.
Yes, that's definitely, can't beat the baby cuddles.
No. I wanted to ask, we have a lot of women that we work with that plan adoption, obviously, during their pregnancy, but sometimes even after they've delivered that baby. you're describing a really sometimes difficult baby to soothe, and that can be really stressful, especially if there's already an addiction cycle and stressors and risk factors at home. So with our programming, I mean, we're able to offer the opportunity for women who may try parenting and it may be difficult and stressful, and they may need to work kind of on themselves before they're able to parent this child in a safe way. Is that something that you could see as could be, these are higher risk factor babies to care for even?
So babies with neonatal absence syndrome, like we said, a baby that's excessively irritable, has a really high-pitched cry, difficult to console, can be challenging even for trained medical staff to care for, because all you want is for the baby to be comfortable and well cared for, and unfortunately the signs of withdrawal don't always go along with that, even though we do the best we can. So it can be challenging for women who are battling addiction at the same time to care for these babies, because even after they're off, if they require medication treatment or don't, but when they're ready to be discharged, they may still have some signs of withdrawal that are able to be mitigated by non-medication therapies. But I would encourage them just to use their resource and to know their resources available. We talk a lot in the NICU for all of our families, not just babies with neonatal absence syndrome, about the period of purple crying. And it talks a lot about different ways you can intervene to soothe the baby, and then ultimately create a safe environment if you need a mommy timeout or a parent timeout, and to set the baby in their crib safely and just take a deep breath away to regroup yourself and then continue. But definitely use your resources and any sort of community or support you would have to help care for the baby.
Absolutely. And I know that in the NICU, you guys are constantly working with families on understanding their resources and plugging them in and helping them stay connected. What advice do you have for families who are wondering if they are capable or that they can parent a child with a background that may have drug exposure?
I think, you have to sit down and know yourselves and know what you're looking for and what you feel capable of. It's hard to describe because every baby with neonatal absence syndrome is so different, even if exposed to the same type of medications or illicit substances. They present very differently, and what therapies they require can be very different, and how long they show signs of withdrawal for can be very different. So I think you just have to do the best you can, and if you think you're up to it, I think that's wonderful. These infants, if they are being placed up for adoption, definitely need good, strong homes. And if it's not for you, then that's okay too. I think knowing that ahead of time is really important, and having those conversations prior to the parenting process is important as well.
Well, Kobi, thank you so much for this conversation today and just the education for our families. We have a lot of resources that we'll provide in our show notes about some of the topics that we've talked about today for our families. And so we just thank you so much for the conversation and for the time just to understand more. So glad that you joined us and hope to have you back someday.
Thank you so much for having me.
Absolutely. Thank you for joining us for another episode of Reframed. If you want to drop us a note or give us a topic that you'd like to learn more about, you can email us at podcast@gladney.org. Thanks for tuning in, and we'll see you next time.
Thanks for listening to the Reframed podcast. Be sure to visit gladneyuniversity.org to access the show notes and discover upcoming trainings at Gladney University. We'd love your feedback, so please head to iTunes and rate, review, and subscribe. Until next time.